Hi, I'm Brittany Phillips. I'm a registered nurse with my bachelor's degree. I'm currently working towards my master's degree at University of St. Augustine, and I am in the Evidence-Based Practice for Nurse Leaders class. Today I'm going to be giving you a presentation on reducing hospital readmissions using nurse-led medication management programs. Let's get started. Let's preview this presentation. So we're going to talk about my practice problem, which, like I said previously, is reducing rehospitalizations due to medications. We're going to talk about a PCOT question that I would like to answer. We're going to talk about my search strategies that I use to identify literature to support my PCOT question. And I'm also going to review my synthesis of the literature that I found. I'm going to talk about the setting in which I want to change and implement my evidence-based practice related to my PCOT, and we're going to discuss what that proposed plan will look like. We're also going to talk about an evaluation plan and data and analysis related to my PCOT and research. And then towards the end, we're going to discuss a plan for dissemination in order to get the information to the public, and lastly, a conclusion regarding my presentation. So let's talk about my practice problem and its significance. Readmission to the hospital can be influenced by so many factors like medication management, social detriments of health, patient compliance and education, and even discharge follow-up. Readmission rates related to medications is straining for patients, insurances, healthcare facilities, and their staff. For example, patients can experience emotional and mental stress related to the readmission, while also losing trust in the healthcare system. They can be physically harmed if the medication orders are not followed. Finances can become a burden if insurance doesn't cover readmission costs or may not be able to afford copays and deductibles. Worst is if they do not have any insurance or have loss of wages related to the hospital stay. Healthcare facilities are also affected financially, with the estimate of the readmissions in the U.S. cost right around $100 billion a year. That's right, you heard me, $100 billion a year. Studies by Schronenberger and Meyer-Masadi in 2023 and Utluktovic in 2021 show that medication-related readmissions range anywhere from 16 to 21%, and of those, 40 to 69% are considered preventable, depending on preventability assessments. Federal regulations require home health agencies to complete a medication reconciliation upon admission. If the quality of these reconciliations was improved, we could fill the ethical obligation of providing quality of care to patients and prevent rehospitalizations. Nursing intervention utilizing a medication management program could improve patient adherence, understanding, and prevention of errors. Now remember, PCOT stands for Population, Intervention, Comparison, Outcome, and Time. My PCOT question is, in adult home health patients, does a nurse-led medication management program compared to standard medication reviewed during routine visits reduce hospital readmissions over a 2-month period? Population focuses on adults over the age of 18 that receive home health services and are prescribed medications from their primary medical provider or hospital stay. There are no limitations on the diagnosis, gender, or location. The intervention is to implement a nurse-led medication management program that the home health nurses will utilize to provide education, assist with care transfer and locating affordable medications, pre-filling medication planners, and provide regular check-ins for compliance. This will be compared to the minimum requirement of federal regulations at start of care to review the medications. My desired outcome is to reduce hospital readmission rates as evidenced by measurable data related to incidence rate of readmissions for patients utilizing the program compared to rates prior to implementation. This will be reviewed over a 2-month period as hospitals track readmission rates in a 30-day period, but home health agencies report based on a 60-day period per Medicare guidelines. Now let's review my search strategy. I utilized Google Scholar and the University of St. Augustine's library to identify different literature that would support my PCOT question. I used the Google Scholar and Sinahall, Science Direct, PubMed, and the Directory of Open Access Journals as databases to identify and find my articles. I use the following key terms listed here in the middle in a combination of all or bits and pieces of each one to identify the literature that I was able to find. My inclusion criteria included full text, peer-reviewed, published between the years 2019 and 2025, and in English. I did exclude anything that had primary care, as it generally didn't apply to my PCOT question. Now, my search did provide over 22,000 articles, and I had to weed through them. Quite a few were duplicates or not related to my PCOT question, so I was able to weed it out quite a bit. Once I had gone through a lot of them, I identified about 41 as potential to support my PCOT question based off of the titles and abstracts. Then I continued by reading the articles and the abstracts and reduced it down to 13 that I decided would work. After I thought about it some more and evaluated the articles further, I reduced this down to 9 due to poor quality of the studies within the articles themselves. 4 of those studies were utilized for my synthesis matrix. To synthesize the literature, tables for primary, quantitative, research evidence, and evidence summaries were filled out to assist in completing a synthesis matrix, as you can see here. Across the 4 studies, it deemed that medication reconciliation and education are needed in order for patients to be successful. 3 out of the 4 noted that nursing follow-up visits in the home were crucial. There was one study that also deemed that access to 24/7 on-call services showed a significant difference in the prevention of hospitalizations compared to studies that did not have this feature. Due to the large difference this seemed to make, it seemed prudent to include in the changes to be made. The evidence is supportive of a nurse-led medication management program to focus on medication reconciliation to improve patient safety, prevent prescribing errors and mismanagement of medications, and increase adherence. Medication education should be provided to each patient and caregivers utilizing a multiple disciplinary team and technological resources. Nursing follow-up was also a common theme and allows for nurses to monitor adherence and potential adverse reactions while also enhancing communication. The recommended evidence-based practice change is going to primarily be seen in home health agencies to provide services to adults over the age of 18. However, there are several stakeholders and institutions that will need to be involved in order to make this change as successful as possible. Stakeholders, such as the one listed here, would benefit from the change financially and workload, improved quality outcomes, and more. They include patients, patient families, the hospitals, medical providers, insurances, home health nurses, and the pharmacies. The institutions that may have a direct change made to them are also listed. The primary one is going to be the home health agency, as their nurses will act as the hub and bridge to gap between the other entities and the patient. Implementing a nurse-led medication management system would take multiple steps to complete. Using Lippitt's change theory, there would be 7 steps that would need to be completed in order to implement the EBP, or the evidence-based practice. The first is recognizing the need for change. As I've already identified the need for change in regards of hospitalization rates related to medications, it is important for me to ensure that others are made aware of the problem as well. Once I have made others aware, it is vital to build relationships with other entities within the community. This would include home health agencies, their nurses, hospitals, local healthcare providers, and pharmacies to collaborate in defining the problem and then setting goals and action plans to address them. Although my PCOT already addresses one outcome goal, there may be others within other entities to make the program successful. Implementing the nurse-led medication management system would take time and planning on the part of the home health agency to create policies, procedures, and resources for the nurses to utilize. This may include formulating an interdisciplinary council to create their items, along with educating the nursing staff on policies, procedures, evidence of EBP, change improvement, medications, and interventions that the nurses will need to utilize. This also includes routine check-ins with patients to allow education, questions, and identifications of concerns. Which leads me to gaining acceptance from the staff and patients. We have to have their buy-in. Explaining the why behind their change, along with frequent follow-up and check-ins from leadership, will be crucial to ensure that the policies and procedures are completed. Collecting data and feedback may also be completed at this step to allow the adjustments to be made for improvement. The final step is the redefinition of the relationships so that the community partners can communicate and work together to ensure the nurse-led medication management program is successful. This could also be through implementing policies or memorandums of understanding between entities to further the relationship and secure success of the program. Now let's go over my evaluation plan. The criteria to evaluate are the readmissions linked back to medications. Data collection to answer my PCOT question will be the readmission rates over a 2-month period prior to implementation of the program, as well as a 2-month period after the implementation of the program. I will also need to collect data on adverse drug events, medication adherence rates, and patient feedback. This way I can possibly connect more or find the reasons as to potential readmission rates related to medication non-adherence or other problems. The tools for data collection are primarily going to be through the EHR and patient surveys. So my electronic health record is going to allow me to look at hospitalization records, and I'll be able to have reports on adverse drug events and medication adherence rate reports. My patient surveys, I'll want to survey their satisfaction and medication management understanding. Now during all of this data collection and analyzation, I'm going to want to make sure that I have confidentiality and security of the data. So I'm going to limit access of control and or have access control to the program. I'm going to have anonymization of all of the patient's data, and I'm also going to look at data encryption to ensure that we have that extra layer of safety. As far as data analysis goes, the paired t-test will be able to allow me to compare means of hospital readmission rates, compare adherence rates, and adverse reaction rates, providing a better understanding of whether or not this program is successful. My plan for dissemination is more than just within the facility itself. So institutionally, I'll utilize PowerPoints and show before and after implementation comparison of the data that was collected so that the staff and company understands why we did what we did and to prove and show that it was or wasn't successful, with the hopes that, of course, that it is. Now, I'm hoping that we would also then invite stakeholders to a local venue within the community and present the PCOT, the literature synthesis, the data analysis to different community boards and all of the stakeholders that had their input and buy-in for this particular program. I would then hope to be able to publish and present my information at conferences for others to be able to replicate and do in their own community so that we can improve awareness of this problem, as well as have more literature review and more research on this topic. In conclusion, rates of preventable medication-related readmissions are just too high, and it is the responsibility of healthcare providers to change that. Implementing a nurse-led medication management system for home health patients could potentially improve the quality of care for patients, their financial burdens, and the financial burdens of healthcare facilities, and adequately meet the needs of patients discharged home. Based on the synthesis of literature, further studies must either be identified or completed to have strong evidence to support the practice recommendations, as I would currently rate it a grade B based on the Johns Hopkins evidence-based practice model. I hope that you have enjoyed my presentation, and I will be providing my references on the next 2 slides for your convenience. Thank you, and I hope you have a great day.